Okay, let's unpack this. We got a stack of notes here, really important information, covering a topic that demands your full attention, especially if you're in or heading into the world of childbirth care.
Definitely.
Think of this as us taking those revision notes you have on a specific obstetric emergency, shoulder dystocia, and turning them into something clear, memorable, and high yield for you.
Exactly. We're diving deep into this material, sort of guiding you through what this critical situation is, why it happens, who's most vulnerable.
And crucially, how you recognize it and manage it when, every second counts.
Right. Our mission is really to make sure you walk away from this feeling much more confident about the key details outlined in these notes, ready for revision or maybe even a real-life scenario.
Perfect. So let's get right into it. What exactly is shoulder dystocia? How do these notes define it for us?
Well, the core definition here is that it's an obstetric emergency. It happens during childbirth.
An emergency. Oh, hey,
And the critical event is that the baby's head has been delivered, but then the shoulders get stuck behind the mother's pubic bone.
right. So it's specifically difficulty delivering the shoulders after the head is already out.
Precisely. The head's delivered, you think, okay, nearly there, and then blockage. It's not just slow progress, it's this specific mechanical problem.
Got it.
And the material clarifies it happens during a vaginal cephalic delivery, so head first, vaginal birth.
Makes sense.
The specific mechanism highlighted is the impaction of the anterior fetal shoulder on the maternal pubic symphysis.
The anterior one, the one facing the front.
Exactly. That shoulder hits the pubic bone.
Yeah.
And this isn't just a delay. It causes both maternal and fetal morbidity, serious consequences potentially.
And it falls under the broader term dystocia.
Yes, dystocia just means difficult labor, but shoulder dystocia is a very distinct and urgent type.
Okay. Head out, anterior shoulder stuck in the pubic bone. Emergency. Potentially serious. So why does this happen? What factors contribute based on the information we have here?
The material points to several things, often working together. You could almost think of it, like the 3 Ps of labor passenger passage powers. But it's usually most related to the passenger, the baby's size or position relative to the passage, the pelvis.
Okay, let's break those down. What about the mother's pelvis, the passage?
So the notes mention maternal pelvic abnormalities. They talk about different shapes like a round brim pelvis being generally good for birth, whereas a long oval brim might be less favorable.
Interesting.
They also suggest a small pelvic brim might be suspected if the baby's head hasn't engaged by 37 weeks, especially in a first-time mom. And conditions affecting the bones, like scoliosis, kyphosis, or even rickets, could potentially alter the pelvic shape too.
So the actual physical structure of the birth canal can predispose someone. What about other factors related to the mother?
Other things listed are excessive maternal weight gain during pregnancy, having gestational diabetes, or pre-existing diabetes mellitus. Advanced maternal age is also mentioned.
Okay, weight, diabetes, age, and factors related to the labor itself.
Yes, prolonged labor is a factor. Also, the use of labor-inducing medications, specifically oxytocin.
Ah, oxytocin. That's interesting because,
Right, because the notes later make a point that oxytocin is not used to manage shoulder dystocia itself. You can't just force through a mechanical blockage with stronger contractions.
crucial distinction.
But its use during labor can be a risk factor. Maybe if it leads to rapid descent before the shoulders are aligned properly, or maybe the labor it's used for is already complex for other reasons.
So a risk factor for it, but not a treatment of it.
Yeah.
Got it. The material also specifically lists fetal factors, right?
Absolutely. And the big one, highlighted multiple times, is fetal macrosomia.
Meaning a large baby.
Exactly. The notes define this specifically as a birth weight of 4.5 kilograms or more. A biggie baby just has bigger shoulders, making that impaction much more likely.
4.5 kilos. That's a number to remember.
Definitely. Other fetal factors mentioned include position or lie, but it's important to remember shoulder dystocia happens in a head-first presentation. So while breech or transverse are difficult deliveries, they aren't this specific problem, but the baby's size and how it fits through the pelvis are key fetal aspects here.
Right. So knowing why it happens naturally leads us to who is most at risk. What are the key risk factors we need to be aware of from these notes?
Okay, the notes give us a pretty clear list of predictors. High maternal body mass index, BMI, is one.
Okay.
Closely linked, as we mentioned, are gestational diabetes and pre-existing diabetes mellitus again, because diabetes is strongly associated with fetal macrosomia.
So maternal weight and diabetes are major red flags,
Yeah.
often leading to those bigger babies.
Exactly. And fetal macrosomia itself, that birth weight of 4.5 kilograms or more, is explicitly listed as a top risk factor.
Makes sense.
Past history is also a strong predictor.
Yeah.
If someone has had a previous history of shoulder dystocia, their risk is higher next time around.
If it happened once.
Right, the conditions might be similar again. Post-term pregnancy is another risk-longer pregnancy, potentially bigger baby. We've already touched on maternal pelvic abnormalities and excessive maternal weight gain.
And then the labor-related ones.
Yes, risks related to the labor process itself include prolonged labor, induction of labor, oxytocin use, and assisted vaginal delivery, like using forceps or a ventouse. If you're already needing help to get the head out, it kind of signals potential difficulties lower down.
Okay, so it's this mix of maternal factors, baby size, and how the labor unfolds. For revision, maybe think big baby, diabetes, past problems, slower assisted labor, and pelvic shape as memory hooks.
That's a good way to summarize the main categories, yeah.
Now, how does this obstruction actually happen physically? The notes touch on the pathophysiology.
The mechanism described is pretty direct. It's the physical process where the baby's shoulder, specifically the anterior one, facing mom's front, gets wedged or stuck behind her pubic bone.
Just physically stuck.
Physically stuck. This wedging creates a mechanical obstruction, stopping the rest of the baby's body from being delivered normally.
And it's that physical blockage that leads to the problems.
Precisely. Because the baby is partly delivered but can't come out fully, they're vulnerable. Compression, lack of oxygen, potential injury as the body is trapped. This links directly to the complications we'll discuss later, like nerve damage or hypoxia.
It really highlights why speed is so crucial. Now, this situation, difficult labor after the head is out, could it be confused with other birth issues? What does the material list as differentials?
The notes mention a few other causes of difficult labor that might need considering, like breech presentation, malposition, maybe a face or brow presentation, or even something like a cord prolapse.
And the key point here.
The absolute crucial point, which the notes underline, is that differentiating is essential because the management steps are completely different for each one.
Right.
You wouldn't, for instance, use shoulder dystocia maneuvers if the cord had prolapsed. Quick, accurate identification is vital.
Knowing what it isn't is just as important as knowing what it is, so you do the right thing. Okay. How common is this? Shoulder dystocia. What do the notes say about epidemiology?
They give a prevalence range. It's estimated to occur in about 0.2% to 3% of vaginal deliveries.
0.2 to 3%.
Yeah, and they do note that the prevalence varies. That could be down to different populations studied or maybe slightly different definitions or reporting methods used.
So not in every birth by any means, but common enough that every delivery team needs to be absolutely ready for it. What does it actually look like when it's happening clinically? What are the signs?
The material describes the clinical features. The primary, most obvious sign is simply that difficulty in delivering the baby's shoulders after the head has already come out.
Okay.
But there can be earlier hints sometimes. A prolonged second stage of labor, that's before the head delivers, might raise suspicion, although that's less specific on its own.
But a classic sign mentioned is?
Yes, a very striking sign is retraction of the baby's head back against the mother's perineum right after it's delivered.
Ah, the turtle sign.
That's the one. The head delivers, maybe even pops in and out a bit with contractions, but then pulls back tightly against the opening, like a turtle pulling its head in. It's a clear visual cue that the shoulders are caught.
Definitely a high-yield visual for revision.
And then, obviously, the inability to deliver the rest of the baby's body despite appropriate effort and traction.
Okay, so you see the signs, maybe the turtle sign. How do we assess the situation in the moment? What investigations are used?
Well, the notes really emphasize that the diagnosis of shoulder dystocia is primarily clinical. You see it happening.
Right, based on observation.
Exactly. Investigations play more of a supporting role, often things done beforehand or used to monitor during the event. Continuous fetal monitoring is crucial during the emergency to check on the baby's well-being.
Makes sense.
Ultrasound can be used before labor to estimate fetal size, helping identify that macrosomia risk factor we talked about. But once the head is out and dystocia occurs, ultrasound isn't really used for diagnosis or management at that point.
And pelvic assessment. Evaluation of the mother's pelvic anatomy might be done antenatally or suspected during labor if descent is poor, again highlighting a risk factor. But it's not how you diagnose the emergency itself in the moment.
So diagnosis is based on what you see and feel during delivery, supported by prior assessment and ongoing monitoring. This brings us to the absolute critical part, management. The notes are detailed here because, as we said, it's an emergency. What's the immediate protocol?
Immediate absolute recognition. That's step one. Time is everything here. Once you suspect or identify it, the first move is the urgent call for senior help.
Get back up.
Fast! Yes. The notes specify calling a senior obstetrician, midwife, anesthetist, and pediatrician. You need a full team.
Right, not a solo job. Get the experts there ASAP. And what are the absolute don'ts? What must you avoid doing?
The notes are very firm on this. Two big ones. First, do not ask the mother to push.
Why not?
It can actually worsen the impaction, driving the shoulder further in.
Okay, no pushing. What's the second?
Absolutely no fundal pressure, pressure on the top of the uterus. The notes explicitly state this is highly risky. It's associated with significant neonatal complications and even uterine rupture.
Wow. Okay, critical safety rules.
Yeah.
Avoid maternal pushing and absolutely no fundal pressure.
Got it. So help is coming, you're avoiding the don'ts. What's the primary initial maneuver you should try?
The first line maneuver, the go-to first step, is the McRoberts maneuver.
McRoberts, how does that work?
The notes describe it as sharply flexing and abducting the mother's hips, pulling her thighs up towards her abdomen.
Okay.
This action changes the pelvic angle relative to the spine. It sort of flattens the lower back curve, the lumbosacral angle, and this effectively increases the functional space in the pelvis. Often that alone allows the shoulder to slip free.
Just changing the mother's position can make that difference.
It often does, and is frequently performed at the same time as adjunctive suprapubic pressure.
Suprapubic pressure. Yeah, that's pressure applied externally, just above the mother's pubic bone. The idea is to try and push the baby's anterior shoulder sideways, either dislodging it directly or helping rotate it into a slightly wider part of the pelvis.
So McRoberts plus suprapubic pressure. That's the initial external approach. Changing angles, targeted pressure. If that doesn't work, what are the next steps, the second line maneuvers?
If McRoberts and suprapubic pressure don't resolve it quickly, you often need to move to internal maneuvers. The notes mention performing an episiotomy at this stage.
To cut the shoulder free.
No, importantly, not to release the shoulder itself. The episiotomy is done to create more room in the perineum, allowing the practitioner to get their hand inside more easily to perform those internal rotation maneuvers.
Ah, okay. Episiotomy for access. Then what internal maneuvers are listed?
There are a few. Rubin's maneuver involves inserting a hand and pressing on the back surface of the baby's posterior shoulder to try and rotate it forward, adducting the shoulder. Another is the Woods to screw maneuver. Here, you insert a hand, usually behind the anterior shoulder, and rotate the baby, kind of like unscrewing them, trying to turn the anterior shoulder towards the posterior.
Trying to rotate the baby out.
Exactly. A third option is attempting to deliver the posterior shoulder first by reaching in, finding the posterior arm, and sweeping it across the baby's chest to deliver it.
So rotating the baby or delivering the back arm first from the inside.
Yeah.
Are there other more drastic measures mentioned?
Yes, the notes do mention symphysiotomy, which is cutting the pubic symphysis cartilage, and the Zavanelli maneuver.
Zavanelli.
That's pushing the baby's head back inside the uterus to then perform an emergency C-section. However, the notes are very clear. These are not first-line maneuvers. They carry significant risks of maternal morbidity and are considered measures of last resort.
Definitely sounds like it. Last resorts only. And just to circle back, the notes reiterate the point about oxytocin here in management.
Yes, they state clearly again, oxytocin is not indicated in managing shoulder dystocia itself. The problem is mechanical, not lack of contractions at this point.
Got it. Now, the notes also include specific NICE guidance about managing labor in diabetic women. How does that connect here?
Well, since diabetes is such a big risk factor for macrosomia, which in turn increases the risk of shoulder dystocia, managing labor proactively in diabetic pregnancies is key. It's about prevention, really.
Makes sense. What does the guidance suggest?
The NICE guidance mention is about timing the delivery to potentially avoid letting the baby get excessively large. For normally growing fetuses and diabetic mothers, elective delivery can be offered. More specifically, for women with diabetes, induction of labor or a planned C-section is recommended between 37 weeks exactly and 38 weeks and 6 days.
So planning delivery a bit earlier.
Yes, and the notes stress that the risks and benefits need careful discussion, especially if the estimated fetal weight is already thought to be over that 4.5 kilogram mark when you're having that conversation. It's a preventative strategy based on known risk.
Right. Planning ahead for those at higher risk. What about planning a delivery if someone has actually had shoulder dystocia in a previous birth?
The material suggests that decision needs to be a joint one, a detailed discussion between the mother and her obstetric team.
What factors go into that?
They should weigh things like any injuries sustained during the previous dystocia, the mother's own feelings and preferences, and, of course, the estimated size of the baby in the current pregnancy. It's very individualized.
That makes perfect clinical sense. And finally, on management, the notes really stress preparedness and documentation.
Absolutely critical points. The notes strongly recommend regular departmental training on managing shoulder dystocia, ideally annually. Simulation-based training is highlighted.
Practicing the drills.
Exactly, because you need to perform these maneuvers smoothly and effectively under pressure. And documentation is vital. Meticulous, accurate recording of everything that happened.
What specifically needs documenting?
Things like which shoulder was anterior, the exact time interval from delivery of the head to delivery of the body, that's the head-to-body interval, and using a structured performa or checklist is recommended to ensure all key steps, timings, and personnel are captured.
Training, simulation, strict documentation. Essential takeaways for handling this emergency.
Yeah.
Okay, looking at the outcome then, what's the typical prognosis according to these notes?
The key message is that prognosis really depends heavily on timely recognition and appropriate skilled management.
So, if it's managed well,
If it's recognized quickly and the maneuvers are performed effectively, the outlook is generally positive, often leads to successful delivery without long-term issues. However, and this is a crucial caveat in the notes, there is still a risk of birth injuries occurring, even with the best efforts.
right, prompt action is the best course, but injury remains a known possibility. Let's talk about those potential issues, the complications listed for both mother and baby.
For the mother, the notes list several risks. Postpartum hemorrhage, heavy bleeding after birth is a significant one. The incidence is noted as around 11%.
Okay.
Third-degree and fourth-degree perineal tears, the more severe tears, are also risks, with an incidence given as 3.8%. Other potential injuries include vaginal lacerations, cervical tears, and, more rarely, bladder or even uterine rupture.
Serious potential trauma.
Yes, and there are musculoskeletal and nerve complications mentioned too, like separation of the pubic symphysis, dislocation of the sacroiliac joint, or even lateral femoral nerve neuropathy, possibly from positioning during the maneuvers.
Those are significant risks for the mother. What of the baby, the fetal and neonatal complications?
For the baby, the most frequently cited complication is brachial plexus injury, or BPI, injury to the nerves running from the neck into the arm.
How common is that?
The notes give quite a wide incidence range, from 2.3% up to 16%. It's important that they also state this often resolves without permanent disability, but it's clearly a major concern.
Understandably. What else?
If the delivery is significantly delayed, there's a risk of perinatal morbidity and mortality due to hypoxia, lack of oxygen, and acidosis. Fractures are also a risk, specifically of the humerus, the upper arm bone, or the clavicle, the collarbone. And pneumothorax, a collapsed lung, is listed as a potential, though less common, complication.
Brachial plexus injury, BPI. That's often the first thing people associate with shoulder dystocia, isn't it? The notes have a specific point about that in the neonatal complications section, linking it to other issues.
They do, and it's a really high yield point for understanding the wider impact. The notes explicitly state that brachial plexus injury is the most common cause of litigation related to shoulder dystocia.
Wow.
They also link the severity of BPI to birth weight and highlight that a risk of substandard care is often associated with cases that result in BPI. It really underscores why recognizing it fast, performing the maneuvers correctly, and documenting everything meticulously is so incredibly important, both for the patient's outcome and for the practitioner.
That link between BPI, documentation, and potential litigation really brings home the gravity of getting the management right, and crucially, being able to show you did everything correctly. It's definitely a high-stakes situation.
It truly is, no question.
Okay, we've really gone through the essential information from these notes, covering what shoulder dystocia is, why it happens, who's at risk, how it presents clinically, how we manage it step by step, and what the potential outcomes and complications look like for both mother and baby.
We have, and while it is a serious, potentially daunting emergency, the material consistently points back to the fact that timely, confident recognition and skilled, appropriate management using those established maneuvers are the most critical factors for achieving the best possible outcomes. Preparedness really is everything here.
Absolutely. So here's a final thought for you to consider as you review this. Considering the potential for severe outcomes like brachial plexus injury and the profound impact this emergency can have on both mother and baby, what does this really tell us about the critical role of team communication, regular simulation training, and rigorous adherence to protocol in the delivery room?
Hmm.
It highlights that it's not just about knowing the steps on paper, is it? It's about executing them flawlessly as a coordinated team under immense pressure. That's something to really mull over.
Indeed. It makes this knowledge much more than just, facts on a page. It's about applied skill and teamwork.
And if you're finding this deep dive helpful for your revision and want to explore more topics like this in a high-yield format, remember you might find valuable resources over at pastmlu.com and freemseu.com.
Yes, they are excellent resources, really designed to help consolidate this kind of critical knowledge effectively.
Well, thanks for joining us for this deep dive into the notes on shoulder dystocia. Keep learning, keep exploring, and most importantly, be prepared.